who needs no introduction, but deserves an introduction. So I'll briefly do that. Dr. Margetis is an associate professor now of neurosurgery, orthopedics, and rehab and human performance. He is director of complex spine surgery in our department and is the director of spine at Mount Sinai Union Square. He completed the majority of his training in Greece and before coming to the US and completing fellowships in pediatric neurosurgery at Weill Cornell, where he and I first met. And he was the fellow while I was the peds junior. And then a fellowship in complex spine surgery at the Cleveland Clinic. So his practice focuses on complex spine surgery and instrumentation, and his research is wide-ranging. He's going to be discussing the development of guidelines for intraoperative spinal cord injury. So thanks, Con, for presenting today.
Thank you. Thank you, Peter. All right. Good morning, everyone. We're going to discuss today about the spinal cord injury, actually about the development of guidelines and its application in the intraoperative spinal cord injury. I have developed some experience by working in NAS especially, and also with an international organization called Icahn that its focus is on the methodology of developing guidelines. So I have some experience, and some of what I'll tell you today is grounded on this experience. So let's start first with what guidelines are. So a good definition is that they are approaches to improve the prevention, treatment of diseases, overcoming inappropriate variations. They are based on the best available evidence, and I would like to highlight available evidence because ideally we would like to have like RCTs for every single pathology and have very robust evidence in the decisions that we make. But we'll see that there are many limitations on that, and we have to make decisions and develop guidelines based on other types of evidence. And over the last few years, there has been some evolution in how we develop the guidelines. And in the past, they used to be basically consensus-based, but now there is definitely an evolution in trying to base the recommendations to evidence as much as possible. And also, we're moving away from this qualitative analysis of the literature to a more quantitative analysis of the literature to come up with more robust evidence to have as a basis for our guidelines. So a few definitions. What is an expert? So is somebody who has a knowledge about the disease or has a particular skill in that area. And that's obvious for healthcare professionals that we have the knowledge, we have the skills, but for the guidelines development, we also recognize that some of that knowledge exists also in the patients or the patient representatives who live the disease. So in many of these guidelines, we try to get them involved and get their experience and also have them participate in some of the judgments that we make when we develop these guidelines. Another key definition is that we need to separate what is a fact, which is something we use, what is evidence, which is a fact that we use in support of a conclusion, and what is a judgment. So if I were to say that I did a laminectomy for tumor resection and, I have zero mortality, I mean, that's a fact. But if I say that laminectomy for tumor resection is safe, that's my opinion because it's based only on my personal experience, and I cannot overgeneralize that. The patients that operate might have been very easy cases for some reason, or might have been lucky. So I cannot overgeneralize that. Now, again, we need to try to separate what represents evidence and what is an opinion of an expert. And when we get the experts involved, we need to focus on the evidence that they provide and not necessarily on their opinions. And in some cases where an expert opinion is based on, let's say, the empirical experience of that expert, then we should ask the expert to present that evidence and have that evidence being evaluated by the other members of the panel that develop the guidelines. So the guideline process is, an overview of the guideline process is over here. So we have like a panel that works on that. And we start with formulating what are the questions that we need to ask and try to get evidence from the literature, and we use the PICO framework for that. Then we create this, we call it evidence profile, and then we evaluate the evidence based on some criteria like the risk of bias, the indirectness, and we're gonna see this criteria in more detail a little bit later. Then we grade the overall evidence, and then we evaluate the evidence to come up with some with the guidelines. And in that evaluation, we take into consideration some other criteria. For example, what are the values, the preference of the patients? And again, we're going to see that in a little bit more detail later. And after that process, we come up with a guideline. So the guidelines, we should think of them as recommendations that they're specific and provide an actionable recommendation. And they are intended to help the clinicians, but they can also be used by, for example, governments or other organizations to guide their policy. It can also help researchers identify where's a need to do research, and can also be used by patients when they make their decisions. So there are significant implications. So we need to be very, very careful when we develop the guidelines, because that can affect the health and the lives of thousands of people. So it's a very careful process. So sometimes people consider erroneously that the guidelines are the standard of care. That's a big no. They are not intended to be considered a standard of care. And when we use the term standard of care, we need to think about the medical legal implications that it has, because if something deviates from the standard of care, then it can have it can form the basis for legal action. So we need to be very careful when we say that something is the standard of care. So the guidelines are not supposed to be considered as the standard of care. The clinicians are still supposed to make their own decisions based on the needs of the patient that they have in front of them. And there are many instances that the guidelines cannot be applied. For example, there might be limitations in terms of the equipment that's available, or a specific treatment method might not be available, or in some instances the guidelines are just basically outdated. So you cannot really use a guideline from 2010 today. I mean, many times you cannot use a guideline from 2010 today. So who's developed the guidelines? That's usually done by big organizations, either like professional organizations, like, for example, the North American Spine Society that I've been working in, or some government organizations. And usually they provide the funding, but they also have what we call an oversight committee that takes the overall responsibility for these guidelines. So what are the factors? What are the criteria that we use to select guideline topics? So we basically interested to answer questions that have significant burden to the health of the patient or economic burden to the society, that they're of interest to the healthcare professionals, or sometimes they might be of interest to, for example, the patients or to the insurance companies. We also try to find areas where there is identified practice variation. And we need to find areas that there is no satisfactory guidance available. And also, we need to think of factors like what will be the feasibility of an intervention that I'm going to suggest. The process can be broken down in 18 different steps, and some of the steps are managed by the oversight committee. Some of them is the board that is working on. And although that looks like serial, but in reality, the guideline development process is non-serial. There are many steps that they can be repeated, or there's an overlap of some of the steps. And for each one of the 18 steps that we saw, there are some very detailed checklists. And the one that we use is the one by Margetis University. And that's an example of just the first step that, the first step has like 11 things on this checklist that we need to consider during the guideline development process. So something similar exists for the other 70 steps. So the checklist, as you can imagine, is pretty detailed. A common issue that emerges is that there are conflicts of interest between the members of the guideline development committee and the topic that they are working on. And so the conflict of interest is when there's a difference between the private interest and the professional obligations. And the conflict of interest cannot be totally avoided. It doesn't necessarily mean that this is negative. I mean, if we want to be involved in the development of new technologies, it is unavoidable to develop a relation with the industry. So it's not something negative, but there's a way on how to handle that. And usually the financial conflicts of interest are the most problematic. So, you know, how do we manage these conflicts of interest? So in general, we try to avoid to include members that have a direct financial or a very relevant indirect conflict of interest. And as I said, you know, in some topics that cannot be accomplished because it might be a new topic and there might be very few people working on. So we need to get like a balance between, we can include them, but there should be a balance between the opinion of those who will be brought in the committee to provide input. Again, there are some more detailed instructions on how to handle that. And what is a big no is that the chair of the guideline development group, because the chair has some, you know, increased responsibilities, the chair should have no direct financial or relevant indirect conflict of interest. So, okay. So what are the questions that we try to answer with the guidelines? So we need to separate what represents a background question. So a background question will be, what is the definition of spinal cord injury? What is the mechanism? And these are not the questions that the guidelines aim to answer. The questions that the guidelines aim to answer is what we call the foreground questions. So the foreground questions basically include the word should. You know, we should think of questions that include the word should. So should we recommend early decompressive surgery rather than late surgery, for example? That's a question that can be answered with guidelines. So one of the key steps in the development of the guidelines is to review the evidence. And when we do these reviews, we usually use the PICO framework. So we try to define what is the patient population that we want to get evidence about, what is the intervention that we would like to evaluate, what is the comparison that we need to make, and what is the outcome that we would like to collect data on. And we need, when we choose the outcomes, we want to choose outcomes that they, for example, they report on the improvement of the symptoms, but we also need to collect outcomes about complications, morbidity, mortality, so negative effects of the intervention. And what is important to keep in mind is that, not everything that is important is measured, and not everything that's measured is important. So there are some limitations in what evidence exists in the literature, and we need to acknowledge that. And although, ideally, we would like to, let's say, collect data on every possible outcome, but the cognitive abilities, it has been shown that if we have more than 7 outcomes, then the analysis of the data it becomes more complicated, and probably the added benefit is very, very limited. So we usually keep up to 7 outcomes. We select the 7 most important outcomes to analyze. And that's also an area where input from the patients is important, because we need to select outcomes that matter for our patients. The typical outcomes is if there's any increase in life expectancy, if there's any reduction in the complications, if the symptoms improve, and the undesirable outcomes is basically any complications or adverse events related to that intervention. And then once we collect the data, then we do the meta-analysis, which is, let's say, the quantitative synthesis of the results. And we need to remember that the systematic review, we need to define the methods we need to be very explicit with the methods that we use to collect the data. And these methods should be fully reproducible. So if I do a systematic review, and then somebody else wants to replicate that the next day, that person should be able to do it and should get the same results that I found. And there are some criteria that we use to assess the risk of bias for the individual studies. And there are many different risk of bias criteria depending on the type of study that we want to analyze. And, many people question whether we should use observational studies because, as we know, correlation is not always causation, but there are some instances that correlation does represent causation. And this has been so, we need to rely on empirical and observational data. And this has been shown with this humorous article from 2003, where the authors tried to find randomized control trials about whether we should use parachute when we jump out of planes. And they came up with a recommendation that those who only basically rely on randomized control trials, that they're welcome to participate in RCT about the use of parachute. As far as I know, there were no volunteers for that study yet. So, although ideal, again, we should use randomized control trials with low risk of bias, but in many instances, the non-randomized studies of interventions, basically observational studies, can still be very valuable. And there are several instances where this is particularly evident. So if we want to extrapolate the results of our RCT to a different population, then we might need to, we don't necessarily need to repeat the RCT, but we might rely on an observational study. Also, observational studies are very good for evaluation of long-term outcomes, because usually the RCTs have a specific time horizon, and beyond that horizon, they might stop collecting data because the funding, for example, didn't cover that. So the observational studies are very helpful for that. And there are some specific criteria about when and how to use the observational studies. And I won't go into more detail on that. So for those who are still not convinced, that they think that we should only be using randomized control trials, I would say that RCTs also have limitations. We consider them the gold standard, but it doesn't mean that they're all, performed, or they all have conclusions that we can rely on. So let me show you that study from 2005 that it was a randomized control trial, and it used the intention to treat analysis approach. So basically what that means is that they did the initial randomization, and then they analyzed the patients based on that initial randomization. So here there were like 87 patients that they were allocated to surgery and 82 that were allocated to physical therapy. But we'll see here that there was significant non-adherence to the treatment, and there was significant crossover from physical therapy to surgery. So you see here 10 weeks, like 31 patients crossed over here, then 9, then 5, then 2. So they came up with a conclusion that surgical decompression is similar to physical therapy. But, if we look, into the data, we'll see that from the 82 patients in the physical therapy group, only 13 received physical therapy. 56 patients from that group actually received surgery. So, if we were to tell a patient, that has common sense that physical therapy, that we can, rely on that study, the patient will look, I don't think that the patient will believe us, because again, from that group, only 13 ended up receiving the, physical therapy. So there are some limitations with RCTs, and that's just one example of the limitations of RCTs. So RCTs, again, do have biases, and there are some criteria that we use to evaluate these biases in the RCTs. So, for example, in these guidelines for acute spinal cord injury, they use this bias criteria. And then once we collect the data, and then we analyze each study for the risk of bias. So again, I want to emphasize that's separate studies. Okay, and then they analyzed the risk of bias of that of every study. And then what the next step is to collect the evidence from each study and then analyze that evidence for each outcome. And then you come up with this strength of evidence table that, again, is about each individual outcome. And the data were collected from the individual studies. And then you evaluate the evidence that you have collected about that specific outcome based on the risk of bias of the individual studies and based on consistency, directness, precision, and we'll see what these criteria are. So let's start first with the first criteria, which is the study limitation, which is a newer term. We don't like to use risk of bias. We like to consider that as limitation of the studies. Is a better term instead of bias, because sometimes bias, sometimes people perceive that as some kind of intention, but in reality, we cannot do the perfect study because there are some objective limitations. So we like to use the term study limitations. And yeah, so that's one of the criteria that we use. And as I said, there's specific criteria on how to evaluate the study limitations according to the type of study. If it is a randomized controlled trial, observational study, systematic review, etc. Then we evaluate if there is any publication bias, and we usually do that with this inverted funnel. And ideally, we like to see like a symmetry in that. If we see something that is asymmetric, then there is suspicion that there might be some publication bias, where basically in the publication bias it means that sometimes the negative results are not reported, or there's some kind of selection in the results that are being published. Then we evaluate the precision of the study, and usually the confidence intervals are useful in evaluating the precision of the study. And we're interested in seeing narrow confidence intervals. If we see very wide confidence intervals, then there is suspicion or the precision of the study or of the outcome goes down. And yeah, so also we have this what we call optimal information size. So that's another way to think about, let's say, the power of the evidence that we have. Like there's the power of the study, but that's kind of the power of the evidence that we have. Ideally, we should have enough data to base our decisions. If we don't have enough data, then the precision of the evidence goes down. The other thing we care about is the overall consistency of the evidence. We like to see that the studies, they point to the same direction. So, for example, in this first graph, there is no consistency because there were studies that saw that there were two studies that saw that the intervention reduced the odds ratio, but there were two studies that saw that the intervention increased the odds ratio for a complication. So there's significant inconsistency in the literature. In this study, in this review here, you see 4 different studies where the confidence intervals do not overlap. So that raises some concerns, but given that all 4 studies, they are definitely in one side of the odds ratio, they saw that there's a reduction in the effect, then we will be okay with that. We will not consider that as inconsistent, because again, all these are under 1. If these all 4 were over 1, we'll have treated that the same. But again, we have like studies that they're on under 1 and over 1 in the odds ratio, and there is some significant inconsistency, and the quality of the evidence goes down. We also care about the directness of the evidence. So basically, we want to rely our guidance on our guidelines on evidence that is directly related to the question that we ask about. And there are some, the directness can come with difference in the population. So for example, we might be interested in, for example, geriatric patients, and we might have evidence from the general adult population. So that is a difference in the population. And similar differences can arise from the intervention, the outcome measures, or sometimes we don't have direct comparison, and we have to rely on indirect comparison. And that's an example where we use, for example, network meta-analysis to come up with indirect comparisons between the interventions. And there are some instances that, I mean, the criteria that we saw before, they, when we have concerns, they rate the evidence down. But there are some instances that we might rate the strength of the evidence up. So if we see that there is a large effect, then we are more confident that we can recommend that specific intervention. Also, when we see that there's a dose-response gradient, then we're also more confident that we can rely on that, on that intervention, on that evidence for the intervention. And there's also this criteria that is called plausible confounders. So an easy way to, it will be easier to understand that with an example. So for example, let's say that we did an observational study and we couldn't really measure the disease severity. And we saw that patients that received experimental treatment had better outcomes. But from our experience, we believe that usually only the sicker patients receive the experimental treatment. So although we have this residual confounder that we don't know if the disease severity plays a role in the outcomes, but most likely if that factor played a role, it would have been like to decrease the effect. Okay, so so if we were to measure that, most likely we would have saw that the intervention had an even more larger and more positive effect. So that's an example of the plausible confounder. And if we think that there is something like that in the evidence, then we will rate the evidence, the quality of the evidence up. So once we have all that evidence collected, then we're going to use the evidence decision framework. And in this framework, we make explicit the criteria that we use, the judgment that we made, and any evidence that we use to make these decisions. And what is criteria? So again, we would like to evaluate how important are the desirable and undesirable effects, and what is the balance between these effects. Again, this is based on the evidence that we have collected. What is the certainty of the evidence? And it's basically all these criteria that we just discussed. So that will make us more certain about the evidence of the effects. And we also care about how the people and usually the patients value the outcomes. And we also need to take into consideration factors like what is the cost of the treatment, and what will be the resource requirements that it will require, and what are the implications for equity, and whether that intervention will be acceptable to the main stakeholders, and in the end, whether that intervention is feasible to be performed, and whether we should, there's no point in recommending something that is not feasible. So in the end, we come up with 5 types of recommendation. There is strong recommendation against, conditional recommendation against, conditional recommendation for either the intervention or the comparison, and similarly, recommendation for the intervention. And there are significant implications when we make a recommendation. And if somebody is a patient and is reading the guidelines, then they might, the way that they should treat a strong recommendation is that most people in their situation will probably want to get the recommended course of action. For clinicians, what a strong recommendation means is that most patients should receive the recommended course of action. Again, please remember that this is not a standard of care, and deviations are allowed, and that's up to the clinician and, the clinician's clinical judgment to make that deviation. And there are also implications for the policymakers and for researchers. And similarly, there are implications for a conditional requirement that for patients that, most people will want that recommended action. And for clinicians, that different choices exist, and that these clinicians should probably consider that recommended action when they make the decision. And there are some instances that the evidence might not be very good. We might have like a low certainty about the quality of the evidence, but we can still come up with a strong recommendation. So, for example, if there is low certainty evidence for benefit, but we're dealing with a life-threatening situation, then we can make a strong recommendation, because even if there is like a small effect, I mean, this can be very, very, very important. So similarly, if we have a low certainty of the evidence and we have a high certainty that there is potential for harm, then we can make a strong recommendation against that treatment. Yeah, so there are like 5 different types. And this particular publication is very, very useful for providing guidance on when to provide strong recommendation in the presence of low quality or low certainty of evidence. A question that usually emerges is what happens if we have low certainty of evidence? I mean, what's the point of providing the recommendation when the evidence is not really there? And it has been shown that clinicians actually they prefer having recommendations, because it's very difficult for a busy clinician to go over all the literature and try to analyze that and do all the work that the guideline committee had to do. So there is a value in providing recommendation even in the presence of low certainty evidence. And again, it can save a significant amount of time from the clinician, because otherwise every clinician will have to repeat the work of the committee. So let's see an application of the guideline development that we discussed in spinal cord injury. Initially, I was planning to do like a more detailed presentation about these recent guidelines, but Dr. Salgado did a very elegant presentation a few weeks ago, so I cannot repeat the things that she said. So I will focus on just the intraoperative spinal cord injury and how some methodology aspects of that. So again, this was done by AO Spine and Praxis organization. These are the organizations that they provided the oversight and the funding for the study. And they used a rigorous methodology where they used the GRADE framework. And for the questions that they asked, the format that they used was the PICO that we saw, and there's another framework, the PPO, for risk factor reviews. And all that was internally appraised using criteria that exist for that. So as we discussed, they use the GRADE approach that is based on the strength of the published literature, but they consider additional factors such as the feasibility, the cost effectiveness, any implications of health equity, and what are the patient values for these decisions and that they had to make. And it was anonymous voting that is important for these processes. So what is the intraoperative spinal cord injury? So they did a literature review and the consensus. They came up with this definition that is a new or worsening neurological deficit that is coming from the spinal cord. And that happened during the course of spine surgery and is diagnosed either intra-op by neurophysiological monitoring or immediately after the surgery based on the clinical examination. So they asked 2 key questions in these guidelines, whether they should recommend intraoperative neuromonitoring for high-risk patients and whether they should recommend for high-risk for intraoperative spinal cord injury patients, whether they should recommend to proactively identify them and come up with a multidisciplinary discussion and have a specific protocol about how to prevent or treat if it happens. So the first thing that they did is analysis of the accuracy of neuromonitoring in the diagnosis of intraoperative spinal cord injury. And they found that actually the motor evoked potentials was basically the best modality to detect that. It was better than the SSAPs and much better than the EMG. And I will say that although that MEP is, the motors are, a better test, but the EMG, given that it provides us with live data, is a very, very useful study. That's my personal note on that. So don't think that only MVP is useful. I mean, SSCPs and EMTs, they have a value because they offer continuous monitoring, while MVPs are intermittent. You know, we ask the neuromonitoring team to run the motors, okay, while SSPs and EMTs are continuous. So don't think that only MVP is useful. All modalities are useful. They just have a different utility. So they did, the meta-analysis, and you see here, this is not meant to be read. This is just meant to show you how much data they had to analyze. So they did a lot of work, and they came up with these summary receiver operating curves. And as you remember, we would like to see that dot as close to the upper left corner as possible. And we can see here for MVPs that actually it gets very, very close to the upper left corner. And that's why the area under the curve is so high. The closer to one, the better it is here. And they evaluated the evidence using the QADAS-2 criteria. And again, this is the criteria to evaluate the quality of the individual studies. And the quality as defined by QADAS-2 is how good the studies were to avoid the risk of bias, and to which extent the studies are applicable to the research question that we have. They collected additional evidence. They did scoping reviews about the management, the types of management for intraoperative spinal cord injury. They also did a consensus session to come up with an overall care pathway. And they did these things because there is, there's not enough literature to prove that one technique is better than the other. So that's why they had to do this consensus session. So there's still some role for consensus and opinion-based recommendations, but as you can see here, they tried to do it in a formal way by doing like a consensus session, doing like a specific study to come up with this care pathway. So what is the frequency of the spinal cord, intraoperative spinal cord injury? So it ranges anywhere from 0 to 61%, depending on the type of the operation. And they found that the better the preoperative neurostatus is, the less there is for ischemia. And we have seen that time after time, when we're operating on a patient with a spinal cord tumor that has some deficits, this patient is more likely to have a neurological event during the case versus somebody who is intact and or has like minimum neurological deficits before the surgery. So that's why usually we want to operate on patients before they deteriorate more. And there are some risks there are some factors that increase the risk for ischemia. For example, older age, concomitant cardiovascular disease, severe myelopathy, the requirement for significant osteotomies or significant deformity correction, the case of spinal cord tumors, and the case of unstable spine fractures. So what are the recommendations? So they recommend that intraoperative neuromonitoring should be employed in high-risk patients that undergo spine surgery. And they also suggest that patients at high risk for intraoperative spinal cord injury should be proactively identified, have a multidisciplinary team discussion about them, and have a protocol that somebody would use in case intraoperative spinal cord injury happens. So let's go into a little bit more detail about that. So we need to identify the high-risk patients and document an accurate neurological examination and make sure that we document in our informed consent process that we believe that this patient is at high risk for intraoperative spinal cord injury. So remember that in some instances, mentioning the risk for paralysis is not enough, but sometimes there is a need to document that we think that this patient is at higher risk for paralysis or neurological deterioration. Then we need to have a multidisciplinary team discussion that usually happens with the anesthesiologist. We need to make sure that they understand the risks, that we define what are the neurophysiological, what are the anesthetic requirements we have from them. and have an ICU bed available for after the surgery. In cases of cervical spine compression or unstable fractures, usually we recommend fiber optic intubation, and our anesthesiologists are very, very good in handling difficult cervical spine cases. We're very, very fortunate on that. And we need to define again what are the MAP targets that we have for the case. We need to be very careful with the patient positioning. We need to define to the neuromonitoring team what we want them to monitor, at what frequency, and have a specific plan about what we want to do. That also usually involves getting baseline neuromonitoring before the flip or before positioning the patient. And that also sometimes require intraoperative imaging, and we need to have like a specific plan of that. In the unfortunate event that intraoperative spinal cord injury happens, there is a protocol we're going to analyze next. And after the surgery, we need to have a monitor bed, ideally ICU setting, perform serial neurological exams, be very, very specific about the pharmacological treatment that we want for the patient, and that usually involves the use of steroids. What are the MAP targets, and whether we need any kind of additional imaging after the surgery. So they proposed, the guidelines committee proposed this intraoperative checklist in, again, the very, very unfortunate event that intraoperative spinal cord injury happens, or sometimes it might be just a change in the neuromonitoring. Doesn't necessarily mean that there is a spinal cord injury, but we need to take that very, very seriously and treat it as though it is a spinal cord injury. So what are the steps that we need to take? So for the surgeon, you need to pause what you're doing and try to evaluate the situation. And then you need to think about what you did prior to signal loss. Did you apply traction? Did you place the rods? Did you do the osteotomies? What was exactly the action that you made prior to losing the neuromonitoring? And you might want to reverse what you did if that is feasible. You might want to do more decompression, especially in cases that there is ongoing spinal cord compression. And you might want to get more imaging to assess whether the hardware was, placed precisely, or whether you need to revise any of the screws. You need, if you don't find any correctable factor, then you might want to consult with a peer. There are actually instances that I got a phone call from orthopedic colleagues that they had an event and they wanted to go there and provide like a fresh perspective about what happened and whether something can be done to reverse that. So that's very, very important. And actually, it can have medical legal implications. If you do that, it definitely reflects much, much better on the surgeon. In cases that you have exposed spinal cord, you might want to irrigate. So these are the actions that you need to consider from a surgical perspective. Then you need to check whether there was some kind of anesthetic agent that was given to the patient and it caused the loss of the responses. Did they give paralysis? Did they give a gas to, did they have to give gas? So what was, you need to check with anesthesiologists to make sure that there was not something from their standpoint that they did and cause that loss of the signals. So that would be like, also you need to speak with the neuromonitoring team to make sure that they check the electrodes, to make sure that it's not a technical reason for that. You might want to repeat or adjust the stimulation parameters. Usually we ask them to increase the stimulation parameters for the motors, for example. And you also want to check that the patient position did not change. So, for example, or you might want to make sure there is no external pressure point. A common example in this case is that, we apply traction of the shoulders to pull the shoulders down in many of the cervical operations. That helps us see the cervical spine on the x-rays, but that traction can actually stretch the brachial plexus. So in many instances, you might just want to take away the shoulder traction. And that's a very common situation that we encounter. And again, you need to speak with the anesthesiologist and make sure that the blood pressure, oxygenation, that all the parameters are optimized from their perspective. And the additional considerations is in some cases, you might want to do a wake-up test. You might decide to abort the operation or stage the operation. And you might want to give steroids, and you might want to plan for immediate CT scan after the surgery. So these are the considerations. This is the protocol that the committee suggested for a surgeon to consider in the event of neuromonitoring signal changing during a surgery. So there were significant challenges during this guideline development process. So they couldn't evaluate what is the impact of the false positives. In many instances, we get a notification that they lost motors, and we realized that actually it was something technical. A needle came out or something like that. This effect of these false positives cannot be quantified based on the available literature, because again, this can it can slow you down during the operation. It can lead you to take action that it was not necessary. So that effect cannot be quantified. And also, there is not basically any significant evidence about, we discussed that protocol, but it's not that it has been proven with evidence that is necessarily the best protocol that, we can come up with. So these are some of the challenges. So there are some knowledge gaps in, that the committee identified from this guideline development, that most of the studies, they are basically correlation studies and do not necessarily represent causation. There are also challenges on how to apply, these things to low to middle income countries. For example, we want to have neuromonitoring on high risk cases, but how feasible it is to have neuromonitoring in a low income country where, even the instrumentation, they can barely afford the instrumentation for a spine case. Would that be cost effective to make that recommendation for the low income countries? So that remains to be shown. Also, we come up with general recommendations for the whole, let's say, population, but there's a need for more specific recommendations for the individual patients. So that's the, personalized medicine, or there are different terms for that. But there's definitely a need for that. And now that we have big data, we can do that, while in the past that we had limitations with the data availability and data analysis methods, that was not really feasible. But nowadays it is. So they say that in the next iteration of the guidelines, they might have more personalized recommendations. So although we discussed what are the high risk patients, but there's more research that needs to be done to make sure that we're able to identify all high risk patients for intraoperative spinal cord injury. And once you come up with the guidelines, your work is not over. You need to make sure that people learn about them and that people are convinced to follow them. So that's the implementation phase. And also you need to remember that there is always new literature coming up. So you came up with the guidelines, it doesn't mean that you're done. No, you need to always keep an eye on the literature and plan to update them, every some specific years, or if there's significant changes in the evidence that's available, then you might want to do the update even earlier than the planned update that you have. So that's from me, and I'm happy to take any questions that you might have.
Con, I wanted to say, first of all, congratulations. That was a great review of an important topic. And I think, as you were suggesting, it'll be interesting to see if big data or AI, one of your other interests, can be used to help identify the higher risk patients. We're lucky to practice in an environment with expert anesthesia and neuromonitoring. Not everyone has that. But I think my question for you is, some of these patients already come in with an injury. Myelopathy, by definition, is injury. And some of those patients, injury plus anesthesia, strokes get brought out, and some of these, myelopathy injuries can be made worse even without a problem. So how do you tease out those factors of pre-existing injury plus just the anesthesia itself and the neurologic suppression and monitoring changes? As you know, some of the people with weak signals or bad myelopathy, they have changes in monitoring even without something that you do differently. So I wanted to know if you have any comments on that.
Yeah. So that's a very good point. So what I like to do, because most of our operation in the prone position, I'm very particular about getting baseline neuromonitoring with the patient supine before we position the patient. And I'd like to know what is the baseline that we start with. I mean, this can still, there's still like a risk for the patient to get a spinal cord injury or deterioration during the intubation process. So, that is not necessarily, let's say, bulletproof, that technique. But I would like to know what is the baseline before I position the patient. And there are instances that we got like a baseline with patient supine, and then we flip the patient and there was a deterioration. And then I double check that the positioning is correct. And then a decision needs to be made. What do you do? I mean, do you abort the operation, or what I have personally done in most of the cases is that I moved very, very, very fast with the decompression of the spinal cord. And I usually first place the instrumentation, but in a case like that, I will first go for the decompression and then place the instrumentation.
Thank you. Great point.
Thank you for that. I think one of the things that I think about with guidelines is that we use them to some degree when we're thinking about meeting the standard of care in QA. And there's something called the substitution test, or when you don't have guidelines, you think about what a reasonable equivalent practitioner would do under the same circumstances to decide whether standard of care was met. Can you comment a little bit on the medical legal implications of making guidelines and expecting practitioners to follow them?
So that's a very good point.
You can stop your screen share there, Tom.
Yeah. So just a second. Peter, that's a very, very good point. So you mean the medical legal implications for the committee that develops the guidelines, or for the application of the guidelines?
I mean for the application of guidelines, that when we make guidelines, then there's a expectation in the legal community that surgeons are following them. So that's I think about for the community of surgeons as a whole. Yeah.
So that's something that the guideline development committees they recognize that and that there are instances that they have used the deviation from the guidelines to make a medical legal case. So that's why they are very, very careful right now to be very explicit when they publish the guidelines that this is not standard of care. That's something that the doctor should consider. But deviations are allowed. Deviations are expected and are allowed. It doesn't mean that this is the law, that this is what the patient, what the clinician needs to do. It's something that the clinician needs to consider. And if there is a need for deviation, they can deviate. But let's say they need to have a reason why they had to deviate from that.
Yeah, as a follow-up for that, 25 years ago, there was a bunch of controversy about steroids for acute spinal cord injury. And there were some NASA sort of studies. And in the end, we, in our guidelines, that was the most controversial thing that I was involved with in writing the part about that. And I think that, even though it was carefully described as not intending to require it, there was plenty of lawsuits on people misapplying it. So even if you have the right intention and the right documentation, guidelines just by definition can be misapplied in the courts.
Icahn, kind of a future imagination question. How do you see guideline development changing with AI? Do you see it continuing in a similar fashion where every 5 years there's a relook at the data? Maybe there's an AI member of the committee who's commenting as well, and adding some perspective, or maybe there's more continuous analysis of data and a kind of a more continuous guideline development. How do you see this changing in the future?
Yeah. So I think that a low-hanging fruit is to have AI help us with the systematic reviews, because that's probably the most time-intensive part of the process. So one way we imagine the use of AI is to continuously search the literature and identifying any new literature that might come up and might be pertinent to the guidelines that we have. And as a first step, just bring it into our attention and then evaluate that. And we think that is significant enough to change our guideline, then update the guidelines. So that will be like, I believe, the first step. Now, having like AI completely autonomously developing guidelines, I think that's probably for further down, the future, because that also might have like regulatory, I think, implications. So it is a possibility that, in the far future, you're not going to have AI fully automating that process. But we're not there yet, and there's significant, we know that there's some, significant limitations of AI. So I don't think we're there yet, but having the AI helping us with the systematic review process, I think that's something that is really safe to consider it, and might be like the next step in the guideline development process. One of the
Yep.
future.
Great, thanks.
Great. Thank you so much. Wonderful presentation, Con.
Thank you, Peterson.
All right, thank you, everyone. We'll see you next week.